Introduction to Nursing Infection Control Part 3. In looking at the lab work, our white blood cell count really becomes the lab value that we focus on because it tells us, is it a viral or bacterial infection? The white count elevates with bacterial infections. It also tells us at what point the infection is at. The neutrophils are about 55 to 70% of the white blood cell count. So at 100%, about 55 to 70% are the neutrophils. Remember, I said earlier they respond rapidly. They come in for the acute infection and they're our first line of defense. In your microbiology anatomy, maybe you talked about the segs and bands. When we look at the segs, those are mature and they are the majority, 50 to 65%. Our immature are called bands, and how I remember that is usually rock bands are immature young kids playing in a rock band. So your immature bands are about 0 to 5% of the neutrophils. When we talk about a shift to the left, that means more immature neutrophils are multiplying during an overwhelming infectious process. That shift to the left is not good, because the body is sending out immature cells to do the work of the mature cells. It would be like when the census is high at the hospital and we call in the kindergartners from the local elementary to come and help us take care of very sick patients. There would be a lot of them, but they're very immature and they would not know what to do, and that would be a shift to the left. When we look at the eosinophils, they're about 1 to 4% of your white blood cell count, differential, and they elevate during allergic reactions and parasitic infections. I remember eosinophils with parasites. If you see a parasite, you usually say, "Ee!" Basophils are elevating during the healing process. 0.5 to 1.5% of your 100% is a basophil. Monocytes are about 5 to 10%. Those are the second line of defense. After the neutrophils hurry up and respond rapidly to that infectious process, the monocytes slowly show up. They're slower to react, but they're big, bulky things, and they're the cleanup committee. They can ingest larger particles of that bacterial infection going on. And then your lymphocytes elevate with chronic and viral infection. So again, can we tell if it's a virus or a bacteria? Yes, by looking at the lymphocytes that elevate with viral infections and neutrophils that elevate with your bacterial infections. In looking at our inflammatory process, it's protective. The vessels react because they're trying to help the body out, and it's the response to an injury or an infection that the vessels respond in that way. So inflammation is really a protective mechanism that brings the fluid, the blood products, and the nutrients to that interstitial tissue where there's injury at. When we look at neutralizing and eliminating pathogens or necrotic tissue, that means it's trying to repair the body tissue to what it originally was. So here's a picture of an infected body part. You can see the outline of where it's deep red. There's swelling and redness. The swelling is from all the blood that has come to that area. The redness is from all the blood. The heat is from the warmth of the blood that has come. The pain is because with all of this extra fluid to this area, it's stretching the tissues, causing it to be painful. And it's tender because it's being stretched, and then the person usually doesn't move it as well, or loss of function as a result of it being so tight. That skin is very tight. When you touch it, it feels very warm. When we see an infection like that, we usually take a pen and draw around where that deep red line is so that we can tell, is the infection spreading or is it getting better from when they were admitted. So we usually demarcate or make a line so we can see where the progression of that redness is. Good to know. Localized versus systemic. Systemic means it's all through the body. It's gotten into the blood and they have a fever. Leukocytosis is your white blood cells elevating. They just feel kind of cruddy, malaise. They don't want to eat. And you can feel the lymph nodes are enlarged during that time. The inflammatory response may be triggered by physical agents such as temperature extremes. One of the things we know with systemic infections is that we often want to hurry up and give them something to bring that fever down. When I have a patient with a new systemic infection, we call the surgeon, we call the doctor, and we let him know, because oftentimes they will want to get blood cultures, and those have to be done before you give an antipyretic and before you would start any antibiotics that they would have. The immune response then is looking at the antigens as they enter the body. It causes the series of changes, and then next time with that immune response, we know that the antigen is neutralized and destroyed because the immune system remembers that they have been sick at one time or another with that illness. In that immune response then, our antigen is that substance in the body, usually a protein, that causes the formation of your antibodies. Antigen is kind of the bad guy, and the antibody is produced by that in response to the bacteria or other invading organism in the body. We switch gears just a little bit, and we're looking at some of the things that we have here in Northwest Iowa. Hepatitis is actually a lot more common, and it's a higher risk if you would get a needle stick than HIV. But we will look at all of these today as we think about some of the infectious things that we have to deal with. HIV is viral. We know that it's spread by blood and sexual contact. It first came out in about 1985. When I started nursing school, we weren't wearing gloves for much of anything because we didn't have the knowledge that we have today. It is not just a gay man's disease. We see many different people having HIV for a variety of reasons. Years ago, they didn't check any of the blood supply, and there are people that are HIV positive because they were sick and got a blood transfusion. When we look at hepatitis A, we know that it's found in the feces. It's transmitted by the oral contact. And there is a vaccine that is recommended, especially if you are leaving the country. Once you have it, you can't get hepatitis again, and the signs and symptoms are fairly chronic. I mean, they last for like up to 9 months, where you can feel pretty sick with hepatitis A. Hepatitis B is from blood and body fluids. There is a vaccine that all healthcare providers and most young people, it's very highly recommended anymore to get the vaccination. I was in my 20s when this came out, and I got vaccinated free as a result of being a full-time employee. And I know they are immunizing now in the schools for the people that didn't get it at birth. Hepatitis C is from blood and body fluids. There is no vaccine, and oftentimes hepatitis B and C do go together with no signs and symptoms. Most people find out either because it damages their liver, or they're great people and they go to donate blood and they get a nice letter from the blood bank saying, please don't come back and donate again with us because you have hepatitis C. There's no prophylactic treatment for hepatitis C after exposure. Early treatment for an infection can sometimes help that process. Hepatitis D always goes with hepatitis B, and so if you have hep B, you probably or if you have hepatitis D, you probably also have hepatitis B from blood and body fluid exposure. Hepatitis E is when you travel outside of the United States. You need to be immunized for that if you are doing some traveling, especially to some of our underdeveloped countries. Good hand washing. Avoid any of the water beverages with ice or water if it's questionable in that area. So as we look at prevention, we know gloves have become the standard. You know, they are standard precautions, and we look at wearing gloves anytime we might be in contact with blood or body fluids. That would include saliva, feces, urine, anything that comes out of that person that, you know, could potentially make us ill. And if you wonder if I should be gloved or not, put gloves on. Wash hands after you take gloves off. Just because you've had gloves on does not mean that that keeps you from wanting or needing to wash your hands. When we look at some of the nursing diagnosis, we look at the risk versus actual. You know, are they at risk for infection because they're immunocompromised, or do they actually have an infection with swollen lymph nodes, a fever? When we look at an IV site, it's red and swollen versus they have an IV site and they're at risk. So a patient that has a red and swollen IV site, it definitely needs to come out. You need to warm pack it, elevate it, has to make an incident report with that because it's an unexpected occurrence, and then you would be sure to let the doctor know. Any IV site that's red and swollen, you would start on the other extremity then to avoid any problems with that site on the one arm that already has an infection. The reason that patients get an IV changed every 3 days as a standard procedure in the hospital is because with that IV is always a risk for infection, because you are going through the skin and allowing potentially germs to get right into the bloodstream. And so we are very careful with our IV sites to, keep them covered, wear gloves, watch for early signs and symptoms of an infection, and then use our nursing judgment to remove them if we think they're starting to look a little swollen, red, any signs of an infection to that IV site. In the planning phase of the nursing process, we look at health promotion. Good infection control begins with prevention. Look at immunizations, personal hygiene, make sure patients are getting rest and exercise, good nutrition. And then in the acute care setting, always the disinfection and sterilization procedures we follow, looking at ways that we can prevent the spread of microorganisms within that facility and knowing the precautions that are used in that facility. The implementation phase of the nursing process is looking then at the CDC guidelines or the OSHA guidelines. They are always updated, and that is a great source of information as to how we should be doing things. Your infection control nurse oftentimes will get updates from the CDC, and it's her job then to spread those new guidelines throughout the facility to make sure they're in compliance. When we look at handling hazardous materials in the red bags, are they being properly disposed of so that it's not contaminating or getting anybody else possibly contaminated? Are standard precautions being followed in your facility? Are we putting on our personal protective equipment, PPE, in the way that it's supposed to be and taking it off? Are we wearing it in rooms at times we should? If I have a patient that maybe I'm only going in the room to put the dinner tray on the tray in front of them and walk out, I still need to probably wear gloves because there's a chance that I might touch that bedside table. When the gloves come off, when I'm outside the room, I need to make sure that I'm washing my hands or gelling. When we look at transmission-based precautions, is that being followed with the masking and the gowning when you have somebody that, has a cough or cold, or they're spreading it through other means that can contaminate others? So when we look at all of these things, we know the red bags and the biohazard bags is only for things that are soiled. So we don't want to use those red bags for just throwing in general garbage simply because it's there. When we have red bags in the facility, they have to be incinerated at a very high temperature, and it's expensive. So we want to make sure that we are putting things in there that need to be in there, but not putting things in there that are just going to be costly to get rid of. We don't want to overfill bags because people can injure their backs or have a lower back injury as a result of trying to lift those. And some places might require double bagging, like you put it in a regular bag and then the red bag goes over the top, so it's kind of a double layer of protection for them. So we want to make sure that they're labeled correctly when we use them. As we look at standard precautions, that is our first tier, always used. It's our most important because these guidelines came out where we look at what we need to do as far as precautions for every patient. So every patient gets standard precautions. If I'm going to help somebody with oral care, I am going to have gloves on at all times. Our second tier then is for specific types of infections, and that's where your infection control nurse comes in and says what we need to do. Our hand washing is always done when our hands are soiled, before and after we have contact with any client, any invasive procedures such as a urinary catheterization, and then after any time we have any contact with body fluids, we've taken off gloves. Those are times that we need to follow those hand washing precautions. Remember we talked about the friction, removing the soil and organisms with that good washing with warm water, plenty of soap, and then the movement of those hands together to cause friction to loosen the bacteria from our skin. Make sure we're cleaning under the fingernails and also removing any jewelry we have to our hands. This is part 3.